In this particular section, we're going to discuss everything about the thyroid cancer. Like all the other cancers, the most important part of understanding any cancer is the workup and the diagnosis, at the same time the treatment and the follow-up. So that's what is going to be the key for treating a cancer patient effectively. So we're going to discuss the basic stuff as well as the advanced stuff on how we are going to make a good follow-up of a thyroid cancer. So let us move on to the thyroid cancer in detail. And before going into the core principles of dealing with the thyroid cancer, let us see some of the basic aspects first. So the basic aspects, in the sense, I'm going to discuss on the classification of thyroid cancer. So how you're going to classify a thyroid cancer. Classification of thyroid cancer, wise, like you can divide the cancer into cancer that originates from the follicular cells of the thyroid gland, which means these are the cells that are going to produce the colloid, and these are cells that are going to produce the thyroid hormone, which are arranged in follicles, which is specific for the thyroid gland structure. And what are the cancers that originate from the follicular cells? We have three cancers. One is the papillary thyroid cancer called as PTC. Second one is the follicular thyroid cancer called as FTC. And the third one is the anaplastic thyroid cancer. Fine. So these are the three basic cancers that originate from the follicular cells of the thyroid gland. All right. So the cancer can also originate from the parafollicular cells of the thyroid gland, otherwise referred to as C cells. Embryologically, also they have a different origin. We have seen that already. So these C cells are going to secrete calcitonin. We know that they are a part of neuroendocrine cell system. And the cancer that originates from the parafollicular cells or the C cells are what we refer to as MTC, medullary thyroid cancer. And finally, you can have cancers that can originate from extrathyroidal tissue as well, which is from the cells which is not intrinsic to the thyroid gland. Like you can get lymphomas and you can get metastatic seeding to the thyroid glands as well. So in general, the metastasis tends to be very rare. But still, if they ask you what is the most common cancer that produces metastasis to the thyroid gland, answer will be the breast. So this is going to be the most common, and certain types of renal cell cancers also are shown to produce metastasis to the thyroid gland. So these are some of the important points that you have to know. At the same time, let us discuss on some of the few points about the anaplastic cancer and the medullary thyroid cancer before we move on to the PTC and FTC, where we are going to discuss in great depth and detail. We know that PTC and FTC are the most common thyroid cancers, whereas PTC is the most common, where 80% of the thyroid cancers generally tends to be the papillary thyroid cancer. But remember, benign tumors, most common is follicular adenoma. But in the malignant cancers, most common will be the papillary thyroid cancer, not the FTC. FTC incidence is hardly 15%, whereas anaplastic is even lesser, less than 1 to 2%. MTC is also rare, approximately around 2 to 5%. So the least of all the follicular cancers is your follicular cell related cancers is the anaplastic thyroid cancer, where you have less than 1 to 2% incidence. Let me finish off some of the important points about the anaplastic thyroid cancer. In general, anaplastic thyroid cancer, prototypical case is an elderly female. That's a prototypical case, even though there are some textbooks that gives equal incidence between males and females, but still in your exam you will get a prototypical case of a elderly female. And that usually there, since I told earlier, the age group will be in the 60s and the 70s, which means age will be usually more than 60 years. All right. And how they present? They are going to present with obviously constitutional symptoms, all right, like weight loss, generalized tiredness and all these things. Plus at the same time, they're going to come with obstructive features, obstructive symptoms and signs, which means they can develop, because a thyroid, this is a rapidly growing tumor and they're going to infiltrate the local structures and they're going to compress on the surrounding structures in the neck. Like they can compress on the trachea and they can produce a stridor and shortness of breath. They can compress on the esophagus, which is closely related to thyroid as well. And they can cause dysphagia. And they can cause recurrent laryngeal nerve palsy, and they can result in hoarseness of voice as well. So usually the main problem with this will be the compressive symptoms. And the average survival is just a meager 5 months from the time of diagnosis, which means it's very, very, very poor prognosis. It's not going to have a good survival rate at all because it's a D-differential, because anaplastic means it's completely undifferentiated, or I can write it as D-differentiated, which means they go to the primitive forms and they grow very aggressively and rapidly. And most of the mutations in anaplastic cancer will be related to the P53. So obviously, whenever you want to have a very poorly differentiated forms, your P53 will be mutated. And this is the, signature mutation of any poorly differentiated cancers, P53, right? At the same time, what you will be getting in the FNAC, because I know there is a swelling and I'm going to do an FNAC. FNAC, you will be getting a sheet of cells that will be very, very poorly differentiated. You'll be getting D-differentiated cells, which will be resembling a giant cell. A giant cell means it might resemble an osteoclast-like. I'm not telling it's an osteoclast, it's osteoclast-like giant cell, or you might get a lot of spindle cells as well. So this is what you're going to get in the FNAC. And when you put the markers, you have to see the markers, what these things are going to exhibit, because they're not going to exhibit any characteristic of the thyroid follicular cell, because they are completely de-differentiated and now they have lost their identity of a thyroid cell, of a thyroid epithelial cell. So if you put the markers in this FNAC specimen, you're going to have this TTF1, this thyroid transcription factor, the thyroglobulin, and the PAX8. TTF1 is an epithelial marker, so can be present in a lot of cancers, but not anaplastic and extremely poorly differentiated cancers, and they're going to be negative for that. A notable point is there will be thyroglobulin negative, because thyroglobulin is something very natural to the follicular cell. They secrete that, so that is negative. That itself tells they have lost their identity and they are no longer resembling a follicular cell of the thyroid gland. But they will be P53 positive, as I told you. So this is what you see in the FNAC specimen, and this itself tells surely this is a anaplastic thyroid cancer. And what you're going to do, the best treatment will be surgery. But remember, we are not going to do a thyroidectomy. Here, you'll be dealing with extremely conservative surgeries. Extremely conservative surgeries like relief of the obstruction. Because here the cancer will be so invasive that you might not get the proper surgical planes to dissect the tumor. Like a radial thyroiditis, where you see you don't get a proper dissecting plane because the infiltrative nature of these diseases. So it's very difficult to resect these glands. So it's better you just give the relief of obstruction to the patient, either by surgery, or you can do some palliative procedures like stenting to the esophagus. You can do these things. So this is what you're going to do rather than a proper thyroidectomy. At the same time, there is no option. You have to go for a chemoradiation, a chemotherapy and a radiotherapy, which might be palliative as well. So these are some of the important features of anaplastic thyroid cancer. And obviously, when you take a biopsy also, you're going to see the same thing almost. You're not going to see anything different. You're going to see the spindle-like cells, and you'll be seeing the osteoclast-like giant cells, and there will be areas of hemorrhage and necrosis because of the high proliferative index of the cancer. So they suck up a lot of blood, resulting in areas of necrosis, and because of high angiogenesis, some small vessels, aberrant ones, which might break, and they can produce a microhemorrhage in the histopathology slide. So clear? So these are some of the important features of the anaplastic cancer. And a few points notable on medullary thyroid cancer. We have discussed a bit of medullary thyroid cancer in the MEN syndrome section itself, but let me discuss some of the other important points as well. Remember, the incidence of MTC is approximately 2 to 5%, and most of the MTCs will be due to RET proto-oncogene mutations, which is present in the chromosome number 10. Remember, RET has intrinsic tyrosine kinase activity. That point is very important. So that is the reason why in advanced malignancies, certain tyrosine kinase inhibitors are actually effective. And one of the latest RET-specific tyrosine kinase inhibitors available, that's called pralsetinib, which we'll be discussing in a couple of minutes. So what are the other features? Remember, there are two types of MTCs. One is the sporadic medullary thyroid cancers, and second one is the familial MTC or hereditary MTCs, where sporadic tends to be the most common. 75 to 85% of MTCs tend to be sporadic MTCs only. Familial generally tends to be very less common, that is somewhere around 15 to 25%. This is the familial MTC. And familial MTCs are again two types. You know that it's associated with MEN2 syndromes. One is MEN2A and second is MEN2B. All the MEN syndromes we know are autosomal dominant inheritance. New mutations have been described, but very commonly they will be familial mutations only. MEN2A is the commonest one among the familial MTCs. So 95% of the familial MTCs are due to MEN2A only, whereas almost 5% of the familial MTCs will be due to MEN2B. But remember, MEN2B related MTCs tend to be extremely aggressive and carries a poor prognosis. That is because the red mutation they develop. We all know the mutation of the red gene that is associated with MEN2A, that is codon 634 mutation. So very, very important. This is the most common mutation that is associated with the MEN2A syndrome. It's associated with the moderate risk of MTC. Then you have a variant of this MEN2A that is called FMTC, where you have only medullary thyroid cancer and not any other thing. So it's called a familial medullary thyroid cancer, which is usually associated with the codon 618 mutation. Remember, there are almost 50 plus mutations identified in the red proton gene in different codon levels. So some important codons are important because these are the ones that will be asked in exams as well. And MEN2B, you know what is the codon mutation that is very commonly associated? That is codon 918 mutation. It's not that common, but related to the extremely aggressive nature of MTC. So very, very high risk of MTC. At the same time, extremely aggressive MTC is associated with this codon 918 mutations. That's why these mutations are very, very important. Even though we divide the device into MEN2A and MEN2B, actually the underlying thing that drives the nature of these cancers is the underlying mutation that you see. Fine. So these are some of the important things that you have to know about the classification of medullary thyroid cancer. And obviously, how they're going to present. So when you see the clinical features, they generally present like a solitary thyroid nodule and very common in females, even though some book tells there is no sex relationship between the patients with medullary thyroid cancer, but still a lot of books do tell that it's very common in females. A slight preponderance is there at least compared to that of the males. And very commonly they will be seen in the upper pole of the thyroid gland. Solitary thyroid nodule in the upper pole. Why in the upper pole? Because this upper pole is the region where you see maximum number of C cells. The C cells concentration or the parafollicular cell concentration is highest in the upper pole. That's why MTCs often come as a solitary thyroid nodule in the upper pole of the thyroid gland. And they also do produce lymph node metastasis, because lymph node metastasis is common in papillary thyroid cancer as well, but they do generally produce lymph node metastasis. At the same time, they can develop hematogenous mets as well. But very common is this lymph node mets only, but hematogenous mets can be seen in approximately 5 to 10% of the patients, where very commonly the hematogenous mets will be to the liver. Liver is one of the very common sites where you can get the hematogenous mets. And they can also produce osteoblastic bone metastasis. This is another important point, because majority of times you will encounter osteolytic metastasis, and MTC is one cancer that can produce osteoblastic metastasis. Since your MTC is coming from the C cells, the C cells is in the neuroendocrine cell spectrum, which means they can secrete other hormones as well, because the neuroendocrine cells are the ones that diverge into different areas in the body to rest in different areas. For example, in the pituitary, they produce pituitary hormones. The neuroendocrine cells that go to the pancreas start producing this insulin, glucagon and all. The neuroendocrine cells that are present in the GIT can produce a variety of hormones, including serotonin. The neuroendocrine cells in the parafollicular cells start producing your calcitonin, which means they are coming from the common neuroendocrine spectrum. So once they de-differentiate and they get poorly differentiated, they can go to their embryonic forms and they start secreting some other different hormone as well. So that is the reason why they can produce a variety of paraneoplastic syndromes. What are the hormones that they can secrete? Obviously, they're going to secrete excess calcitonin, which is a very, very, very important tumor marker for the MTC as well. This is the most common substance that is secreted from the MTC cancer cell. And this calcitonin, if it's in too much excess, they can produce flushing and diarrhea. Flushing and diarrhea, even though they can produce hypocalcemia to an extent, but it's very rare to produce hypocalcemia physiologically. When there is hypercalcemia, they can bring down the calcium to normal range, but producing hypocalcemia is not that common. But they do generally produce this flushing and diarrhea. Apart from that, they can produce a variety of other substances like ACTH, which can result in Cushing syndrome. Usually this is due to ectopic ACTH secretion. And they can secrete a lot of other hormones as well, like serotonin, which can result in development of carcinoid syndrome, or they can also produce VIP, that's called vas-active intestinal peptide, which can produce explosive diarrhea. They can produce CEA. Then they can produce melanin as well. So they can produce even prostaglandin sometimes. So variety of hormones they can produce, calcitonin being the most common. Do not forget ACTH. And they can produce growth hormone also. I mean, one of the important reasons for developing ectopic growth hormone, or even sometimes very rarely GHRH also. These are extremely rare. So the two most common, obviously calcitonin on the first, a little bit of ACTH you have to remember. So there are some PNS that can happen with this medullary thyroid cancer as well. So when you're going to do a FNAC, so what are you going to get? So obviously whenever you encounter a solitary thyroid nodule, STN, and you are going to evaluate this the solitary thyroid nodule through a different mechanism. So once you end up, obviously this nodule in the ultrasound will look like malignant. So obviously you will end up in a stage where you have to do an FNAC. So that's what I'm trying to tell, because we have already discussed in the previous video on how you're going to work up a solitary thyroid nodule. So ultimately a malignant looking nodule, it will end up with the FNAC or an FNAB. So when you're going to do an FNAC, what you're going to see, you'll be seeing something called a spindle cells. Very, very important. So the spindle looking cells, very characteristic. At the same time, they'll be pleomorphic in appearance. You know what I mean by pleomorphism? And they will not be forming any follicles. Obviously, these are not follicular cells to produce follicles. They will be parafollicular cells, which means when they don't have follicles means it's unlikely to be a follicular thyroid cancer. So you can rule out a follicular thyroid cancer. Similarly, they will not have any nuclear features that are specific to PTC. I will be telling you some of the nuclear features. Nuclear features of PTC are what is very important, because a pathologist, if it's coming from the thyroid, the specimen is coming from the thyroid, the first thing he or she looks is the nuclear features of the cells, if it's supposed to be malignant looking up cell. So in FNAC, the PTC has some nuclear features, and in biopsy, they have some concrete nuclear features which you're going to look out for. So definitely there is no nuclear features that are telling you that it could be a PTC. So this will tell you that it's unlikely to be a PTC. That's how we are going to diagnose it's a medullary thyroid cancer. And at the same time, it will not be so dedifferentiated like what you see in anaplastic thyroid cancer, but it will be having some sort of differentiation. But more importantly, there is something called a FNA washout. So when you're going to take an FNA washout, so what do you mean by an FNA washout? So how we do an FNA is not the point here. So when you take an FNA and you produce a smear, there will be some material. After you express all the material from the syringe and you make the slides for cytology sections, and the remaining material within the needle. So we don't want to waste it. So we cannot express that also. At the same time, we don't want to waste it. So how we are going to utilize it is because we are going to mix it with a 0.5 ml normal saline. So you can attach that needle with a syringe containing 0.5 ml normal saline. You can attach the needle and you can push that needle, or you can just flush that material within the needle, and then you can collect it in a sample container and you can send that for calcitonin. You can send that for calcitonin, and the FNA washout will be positive for calcitonin. Suppose if your FNA specimen is contaminated with blood, for example, it's an invasive procedure. There's a lot of chance that it might get contaminated with blood. So in that instance, if you see a gross blood in the FNA specimen, so in that condition, you can send the sample. The same washout sample can be sent, but there the cutoff will be the FNA washout sample should have calcitonin at least more than what your serum calcitonin is. In that condition, it becomes specific for MTC. So obviously, you have to know this FNA washout. It's very good for diagnosing an MTC. So where the specimen, the FNA washout specimen will contain positivity for calcitonin, or you can keep a cutoff of FNA washout calcitonin more than serum calcitonin if it is grossly contaminated with blood. So this is what you're going to see in FNAC. And obviously, what you're going to see in the biopsy. I mean, biopsy is not the way now. So obviously, when you know this patient is going to have a likely to have a medullary thyroid cancer, so what is the next step? So what is the next step you're going to do? So now you know almost certainly that it's a medullary thyroid cancer. So if you ask me the next particular step, I will tell you it's the red gene mutation. So this will be the next step, obviously. So why red gene mutation? Very simple, because you have to know whether it's a familial or a sporadic MTC. Because if red mutation is positive or if the red mutation is negative. The red mutation is negative, straight away I can proceed towards total thyroidectomy after doing some workup. Obviously, I will do a workup for a thyroid malignancy like ultrasound of the neck. I have to see for the lymph node metastasis. A lot of other things are there. But I mean, to be precise, I'll be proceeding ahead with the total thyroidectomy in this case. But if the red mutation is positive in the cancer, then the evaluation and workup must be completely different. So in the sense like, familial MTCs is going to be associated with MEN 2A and 2B syndromes. In the sense like they can have additional tumors as well. So for example, a MEN 2A might have a pheochromocytoma and a parathyroid adenoma, and a MEN 2B can have an additional pheochromocytoma. Here the most important is the pheochromocytoma. Very, very important. So that's what I'm trying to tell. So if the red mutation is positive, I have to definitely rule out a pheochromocytoma. Absolutely no doubt about that. I have to rule out a pheochromocytoma in this setting. So depending on the codon mutation, I also have to rule out a primary hyperparathyroidism. So I can write a PHPT, that's called a primary hyperparathyroidism. So I'd rule out both. So remember, like this primary hyperparathyroidism is not associated with codon 918 mutation. That's why the type of red mutation is very important. So codon 918 mutations generally, that is meant to be, is usually not associated with this hyperparathyroidism. Very important point. So that's why I have to rule out this. The most important rule out is the pheochromocytoma. Obviously, how can I rule out a pheochromocytoma? I'll be doing 24-hour urinary fractionated metanephrines. So remember, currently the metanephrines are the gold standard for ruling out a pheochromocytoma. So I'll be doing either a 24-hour urinary metanephrine, or alternatively I can do a plasma metanephrines as well. I'll be discussing in detail about where to do these facts in the pheochromocytoma section. So, but remember, some type of metanephrine has to be done. Clear? Primary hyperparathyroidism, I can just rule out on the basis of serum calcium and PTH and alkaline phosphatase level. So mostly calcium and PTH is more than enough. So I can rule out a primary hyperparathyroidism. So that's the reason why we go ahead with the red mutation as the next step. But remember, in general, red mutation typically, is available only in few limited centers in our country, where it might take a very, very long time to really, get the red mutation results. So in those conditions, whether it's positive or negative doesn't matter. So if you think the treatment is going to be delayed for long because of the waiting time for the red mutation availability, you can directly go ahead with ruling out the pheochromocytoma and hyperparathyroidism, and you can proceed ahead with total thyroidectomy. Clear? Remember, if you get a pheochromocytoma, suppose if pheochromocytoma is there in the patient along with MTC, then you have to treat the pheochromocytoma first, or you have to optimize the pheochromocytoma first, then only you have to go for the MTC total thyroidectomy. The reason is because in the presence of a pheo, if you touch the tumor, they'll burst out and they will cause a severe catecholamic surge, and there can be death on table also while doing a surgery. Or at least first debug the pheochromocytoma, then in the same sitting proceed ahead with the treatment of the MTC tumor in the same sitting also. So that also you can do, or you can do a 2-stage surgery also, doesn't matter, but always rule out a pheochromocytoma and debulk or optimize the pheochromocytoma first, then touch the MTC if the pheochromocytoma is there in the patient. That's why this becomes really important as far as MTC is concerned. Clear? Suppose if the red mutation is positive, there is one more step I have to do. It's not only about ruling out a pheochromocytoma and ruling out primary hyperparathyroidism, I also have to do some other thing. If the RET mutation is positive, screening of the family members. Screening of family members. Really, really important. And we have discussed in detail about how to screen a family member and when to do a total thyroidectomy in a patient who's having a MEN2A and MEN2B syndrome. Let me tell you some of the other perspective regarding this as well. And just a recap of what we have studied in the MEN syndrome chapter. So you know that you can split the RET gene mutations. You have more than 50 plus types of RET gene mutations. We can split into 3 types for our convenience. One is the codon 918 mutation. Next is the 634 and 883 mutation. And third one is the all other mutations. So we are going to put everything else together. So if they ask you the risk of developing an MTC risk, the codon 918 mutation is going to have the highest risk of developing a medullary thyroid cancer. And 8634 and 883 is going to have high risk, but not highest. But all other mutations, still they do have a little bit of high risk, but moderate risk compared to that of the 918, 634 and 883. Fine. So which means since they have the highest risk of MTC, when you're going to screen for MTC, so the guidelines tell that 918 mutations you have to screen soon after birth, or whenever the moment you diagnose RET mutation, you have to screen for MTC. That's it. Soon after birth, whichever is earlier, right? So when you diagnose the RET mutation positivity or soon after birth, whichever is earlier, you just start the screening for MTC. You will be doing with calcitonin with probably a ultrasound of the thyroid. Fine. So 634 and 883, you're going to screen by 3 years of age, and for all others, you screen by approximately 5 years of age. And when will you do a prophylactic total thyroidectomy? Because the reason for death in these patients is usually the MTC. So when you're going to do a prophylactic thyroidectomy, it should be done within a year. Very, very important point. If it's 918, there is absolutely nothing to do with that. It's within 1 year. That's it. 634 or 883, you can do within 5 years of age. If it's other mutation, apart from the 3 mutations which have been mentioned, again, you can do within 5 years, but there are some guidelines which tell after 5 years also, depending on when you start the screening. But ideal answer in exam will be within 5 years for these mutations. But no brainer, 918 means within a year. That's it. And when you're going to screen for pheochromocytoma, because pheochromocytoma is one tumor that can be seen in all the mutations of RET in any MEN syndrome, 2A or 2B, doesn't matter. So usually pheochromocytoma screening will be done by approximately 11 years if it's a 918, 634 or 883, and you will be doing by 16 years for all the other mutations. Similarly, primary hyperparathyroidism, screening wise, you need not do for a MEN1 syndrome, this 918 mutation, because it's not associated with primary hyperparathyroidism at all, where you will be, screening surely for this 634, 883 and all the other mutations, where you will start the screening by 11 years of age if it's a 634 and 883, and you will be starting by 16 years of age if it's a all the other mutations apart from 634 and 883. For 918, you don't need that, because this 918 mutation, even though they are associated with highest risk of MTC and aggressive forms of MTC, they do not have risk of developing parathyroid adenoma. Clear, there is no need for screening for parathyroid adenoma and primary hyperparathyroidism if it's a 918 mutation. Pheochromocytoma, obviously I'm going to screen with either plasma metanephrines, or I'll be screening with 24-hour urinary fractionated metanephrines, but the key is here is screen with metanephrines. That's the key. That's the current standard for screening or confirming a pheochromocytoma. So we'll be discussing in detail in the pheochromocytoma section in the adrenal glands. So these are some of the points I need to tell you on the screening process of the family members, which is really important. That's why I told you the ruling out of pheochromocytoma and the RET mutation screening is the next step the moment you diagnose or suspect MTC in a FNAC. Fine. Now, next step is going to be the treatment. So after the thyroidectomy, so what is going to be the next treatment or next thing that you have to do after doing a total thyroidectomy? You have to see whether what is the biopsy finding. So which means whether the excision biopsy that you have taken is matching with the pre-surgical diagnosis or not. So biopsy, what you'll be seeing again, you're going to see these spindle cells typically, which are arranged in cell nests. This nest is very important word because this can be seen in many neuroendocrine tumors. So cell nests, and you will have in between amyloid stroma, and there will be calcitonin positive. The staining will be positive for calcitonin. At the same time, other markers that can be positive can be CEA and synaptophysin and chromogranin A. As I said previously in the FNAC markers, all these can be positive, but they're characteristically thyroglobulin negative. Very, very, very important point. The reason why I'm saying thyroglobulin negative is because these cells are not derived from the follicular epithelial cells of the thyroid gland. These are derived from the parafollicular cells, which have nothing to do with thyroglobulin or thyroid hormone synthesis. So this amyloid stroma typically occurs due to the calcitonin only. So this is a form of localized amyloidosis, which might stain with Congo red also. And if you take the pathology textbooks and see, they are given very clearly, this is one form of localized amyloidosis where calcitonin deposition MTC causes amyloidosis of the thyroid gland. Fine, very important point. And what could be the subsequent treatment? So it depends. For example, if you have a metastasis or metastatic MTC or a locally advanced MTC, these patients are good candidates for tyrosine kinase inhibitors that target the RET. RET is a form of tyrosine kinase, I told you. So what tyrosine kinase inhibitors? There are two types. One is selective and non-selective. Currently, only non-selective tyrosine kinase inhibitors are approved. We don't have selective tyrosine kinase inhibitors. It is there in the trials. It's in the phase 3 trial right now. One drug is called BLU-667, otherwise referred to as a name called pralsetinib. So this is in the trials but not yet approved. But there are a lot of non-selective tyrosine kinase inhibitors which are multi-tyrosine kinase inhibitors, which means they target a lot of tyrosine kinases like RET, not only RET, they can target epidermal growth factor, they can target VEGF, vascular endothelial growth factor, etc. So there are some examples of this multi-tyrosine kinase inhibitors, and that is useful for MTC is vandetanib. This is a very important potential exam question. Very, very important, vandetanib. And there is another drug that is used that's called cabozantinib. These are the two things that are generally preferred. Apart from that, there are other multi-tyrosine inhibitors like sunitinib, sorafenib, and these are not that useful for MTC patients. But pralsetinib is a very important upcoming selective RET inhibitor. So it's very selective for RET, 100 to 1000 times more selective compared to other drugs which I have mentioned. So this is about the DKA, and they have tried one drug called the CA inhibitor, this Cas9 embryogenic antigen inhibitor, because majority of the tumors exhibit CEA. So they thought that the CA inhibitors might be useful. So they tried a drug called labetasumab, and the problem is this drug has failed for MTC, so we don't use it. So this drug has failed. Clear? And next thing about the follow-up. How you follow up, what is the marker of choice, tumor marker of choice for following up? Answer will be calcitonin. Again, this is a quite important point because for follow-up of FTC or PTC or any follicular cell-derived tumor, you're going to use a thyroglobulin, not calcitonin. For MTC, it is calcitonin. And radioactive iodine ablation treatment and TSH suppression with levothyroxine. Whether these treatments are helpful or not? Absolutely not. So because these are parafollicular cells, they are not going to respond to TSH as well, nor they are going to respond to your radioactive iodine as well. So they are absolutely useless as far as MTC is concerned. So don't worry about that. So, but these are very, very important treatments for your follicular cell-derived tumors like PTC and FTC. So be careful. So we have discussed in detail and very decently about this medullary thyroid cancer. With this, we will be moving on to the PTC and FTC features. So I'll tell you some of the features. Then after that, let us move and clump everything as a whole and let us see how to diagnose and put everything in a nutshell and go about a thyroid malignancy in some time. But let us finish off the basic features of the PTC and FTC. PTC in general is the most common thyroid malignancy. We know that 80% of the thyroid malignancies are PTC, and together this FTC and PTC alone contribute to 95% of the total thyroid malignancy, because which means these two are the most important thyroid malignancies that we have to study. Features of PTC. First one, we have to know about the risk factors of how you're going to get a PTC. The first risk factor, as far as I know, is the radiotherapy or any radiation exposure to the head and neck area. Very, very high risk. This is supposed to be the highest risk for developing papillary thyroid cancer. And you might get with Hashimoto's. There are two tumors you can get with Hashimoto's relation to the thyroid. One is the thyroid lymphoma and second is the PTC. Yes, still there is a risk. And thyroglossal cyst, untreated thyroglossal cysts may also develop a PTC within themselves. But one interesting point is the fact that these PTCs generally tend to happen in iodine sufficient areas. And even though the validity of this point is heavily questioned, but still this is a traditional point. Given older textbooks, that's why I'm telling this point, it can happen in iodine sufficient areas. And it is common in females. Yes, male-female ratio or female-male ratio is approximately 2:1. At the same time, it happens in the age group of 30s and 40s. Typical exam case is a middle-aged female with a solitary thyroid nodule. Very typical. So presentation, usually asymptomatic, or it will be an incidental presentation or the patient may come with a solitary thyroid nodule. So that's the usual presentation. Even though clinically they present with a solitary thyroid nodule, this tumor is known for its multifocality, which means there will be microscopic deposits elsewhere in the gland as well, like in the contralateral lobe. This is very important point. You will see microcalcifications in many areas. So that's a very important sign of a malignancy in the previous chapter, which I have discussed, isn't it? So that's a very important point. Then what are the metastases? So usually they'll go for lymph node mets. And this lymph node mets can be so early that they can present as a first manifestation in the patient even before the thyroid swelling starts. So that kind of presentation is what we refer to as something called a lateral aberrant thyroid. Very important point again. Clear? But hematogenous metastasis is generally rare but possible. Whenever I tell VA, it means vascular invasion is possible but rare, which means they can result in hematogenous metastasis but still rare. Fine. But lymph node metastasis is the typical of a classic papillary thyroid cancer. At the same time, there are some genetic mutations that you have to know. The usual gene mutations that are associated with the PTC is this RET PTC rearrangements. The RET PTC rearrangements that are very, very common. At the same time, they can have this BRAF mutations. BRAF mutations are quite common in patients who are suffering from papillary thyroid cancer. Clear? Even in sporadic cases. So these are some important points that you have to note about the papillary thyroid cancer. And what about the follicular thyroid cancer? Follicular thyroid cancer, on the other hand, happens in iodine deficient areas in relatively high proportion, but again the validity of this point is very unknown. And usually common in females again, and usual age group where the patients get this FTCs in the 50s and 60s, which is in the middle to the older age spectrum, relatively. And in contrast to the PTC, majority of the FTCs tend to be absolutely solitary. They don't have this microscopic seeding also. They don't have metastasis to the other lobe usually. At the same time, these patients are very, very well known for hematogenous metastasis, which means vascular invasion is extremely common with FTC, follicular thyroid cancer, and that is the reason why they produce hematogenous metastasis. And this hematogenous metastasis is very common in the lungs. At the same time, they can also result in osteoblastic metastasis of the bone. And remember, these metastasis tends to be osteoblastic. At the same time, they tend to produce pulsatile metastasis because of their high vascular nature. very heavy vascularity will be there. That's the reason why they produce this pulsatile metastasis. So this vascular invasion and hematogenous metastasis is the key point for exams as far as FTC is concerned. At the same time, they can produce capsular invasion also, which means this point is again important for diagnosis of a FTC, because they will ask you in exam what is the difference between a follicular adenoma versus follicular carcinoma. The nuclear features, the features that you see in the nucleus of the cell in a biopsy or in the FNAC will not differentiate between a follicular adenoma and a carcinoma. It's the invasion that's going to differentiate between a follicular adenoma and a follicular carcinoma. Clear? When you see, vascular invasion, capsular invasion in a biopsy is equal to FTC. Otherwise, it's a follicular adenoma. Fine. So that's the reason why FNAC cannot diagnose a follicular adenoma versus a follicular carcinoma. Fine. It can tell you a follicular neoplasm, but it cannot tell you whether it's a follicular adenoma or a follicular carcinoma. So you need a biopsy for that, excision biopsy for that. At the same time, the mutation that is associated with this follicular carcinoma is PAX8, PPAR rearrangements. This is what you usually encounter. At the same time, you can see RAS mutations as well. So these are the mutations that are usually encountered in a follicular thyroid cancer. Next, we are going to discuss on some of the variants of this papillary and follicular thyroid cancers. So variants in the sense there are some variants of PTC which are considered to be aggressive. By default, classic papillary thyroid cancer is a low risk tumor only. We are going to discuss about the ATA risk factors for mortality and morbidity in the future in some time. But right now, let us see what are these aggressive histological variants of papillary thyroid cancer. So by definition, these are a bit aggressive compared to the classic PTC. The first one is the tall cell variant. Second one is the columnar cell variant. Third one is the hobnail variant. And fourth one is the Hürthle cell variant. So there are some variants histologically, and these tend to have a little bit of more lymph node metastasis and a little bit of poor survival. Talking about the survival, what is the 10-year disease-specific survival? So first of all, you have to know that this papillary and follicular thyroid cancers may be either well differentiated, which is very, very common compared to that of poorly differentiated. Fine. And anaplastic, as we know the fact that they are undifferentiated or completely de-differentiated. And MTC, on the other hand, tends to be relatively poorly differentiated as well. So what is the 10-year DSS, which means DSS stands for disease-specific survival here. The 10-year DSS for a well-differentiated PTC or an FTC is over 95%, which means excellent prognosis. And for a poorly differentiated tumor, it's only 50%, drastically comes down. And for an undifferentiated or de-differentiated tumor like anaplastic cancer, it's only 20%. Clear? As I told you, the median survival will be often only 5 months in case of an anaplastic cancer. And again, in MTC, it's poorly differentiated, so it tends to be somewhere around 50%. Clear? So this is what is the meaning of this DSS in respect to the your differentiation of the cancer. So these aggressive histological variants tend to be a little poorly differentiated. That's why they have a more lymph node metastasis and reduced survival. And you have two other variants that you have to know. One is called invasive EFE-PTC. That's called invasive encapsulated follicular variant of a follicular papillary thyroid cancer. This is called an encapsulated follicular variant of a papillary thyroid cancer. So it's an invasive encapsulated follicular variant of papillary thyroid cancer. This is a new nomenclature where these patients can have a little bit of vascular invasion and a little increased risk of hematogenous metastasis is also there with this particular group of patients. But intrathyroidal EFE-PTC again carries a low risk of death only. So it is treated like a low risk PTC only. So nothing to worry about that much. Only if it goes extrathyroidally, then it's a little problem. So it again depends on the staging, which we'll discuss in due course. And there is another variant called NAFTP. This is called a non-invasive follicular tumor with PTC-like nuclear features. So first break down it. NI, that's a non-invasive. FT stands for a follicular tumor. And P finally stands for with PTC-like nuclear features. You must be knowing this one particular variant given in old pathology books, that is the follicular variant of PTC. So this is a 2016 revision of that fact. This is NAFTP. The term follicular variant of PTC is no longer used. Instead, we are going to use this NAFTP as a nomenclature. So this NAFTP, as the name suggests, it's non-invasive. In fact, it's considered as benign, not at all malignant by many of the pathologists. At the same time, it has very, very low risk of developing any sort of metastasis, even lymph node metastasis. So nothing to worry much about this. As the name suggests, you can see this will have follicular arrangement, not a papillary arrangement, but they will have a papillary thyroid cancer-like nuclear features. So it's like something in between. So currently it's called as a follicular tumor with papillary-like nuclear features. So that's called NAFTP, very, very low risk of metastasis and will be treated like a low risk PTC only. So we'll be discussing in some time what do you mean by low risk, intermediate risk and high risk. So these are different variants that we have to know. Clear? So now what you're going to do in a real-time case. So we are going to analyze a real-time case which is going to come with a solitary thyroid nodule. What is the next step you will do? That is thyroid function test. Even before going to that, let me tell you what will be the thyroid function abnormality in a thyroid cancer. So if you do a TFT in these patients, how they're going to present. So the TFT will be normal, which means thyroid cancer generally comes with a no thyroid function abnormality. They'll be euthyroid in nature. And very commonly, they'll come with a solitary thyroid nodule only. All right. So that's what you're going to do when you are dealing with the solitary thyroid nodule. The next step I'll be doing is the thyroid function test in the form of TSH analysis. The TSH can be normal or increased, which means it's a euthyroid or hypothyroid picture. Or second, I can do a radioactive iodine uptake if it's a low TSH or if it shows a hyperthyroid picture. So if it's normal or increased, which means euthyroid or hypothyroid, then I'll be seeing if there is any criteria for FNA. All these things we have discussed in the previous video itself. Now I'm just recapping it. If radioactive iodine uptake is showing a hot nodule, which means increased uptake, or I'm having a cold or a warm nodule. So if I'm having a cold or a warm nodule, I'll be again seeing whether the criteria for FNA is met or not, or if it's showing a hot nodule, I'll be considering this as a likely benign lesion only. I'll not be even thinking it as a malignant lesion in the first place. Now, if FNA criteria is met, yes or no. If it's met, definitely I'll be going ahead with FNA. If it is not met, then I'll be just sticking on to ultrasound monitoring in an interval that is again based on certain guidelines. So if the FNA criteria is met, in the sense means what do you mean by the FNA criteria? We've discussed this already. Any nodule more than 2 centimeter, or if a nodule is 1 to 2 centimeter, plus it has suspicious ultrasound features. We have discussed about a lot of features that are suspicious for a malignancy. If it's taller than wider, very, very important. Solid, hypoechoic nodule, irregular borders, central blood flow, microcalcifications, twinkling on B-flow ultrasound. A lot of features are there. So some of the features we have discussed extensively in the previous video itself. Or if it is less than 1 centimeter plus if it has a high risk clinical features. This we have discussed extensively. Again, I'm not going to repeat it. So these are the indications for doing a FNA. If any one of these is there, you can do a FNA. So obviously your FNAB reports are going to come in the form of Bethesda system, which we have discussed in detail again. I just going to explain it verbally, where 1 means non-diagnostic, you have to repeat the FNA. 2 means it's a likely benign tumor, you can go for ultrasound follow-up itself. 3 is ATP of undetermined significance or follicular neoplasm or lesion of undetermined significance. 4 is a definitive follicular neoplasm. 5 is a probably malignant lesion. And 6 is a definitive malignant lesion. So usually when you are going towards a thyroid malignancy, your Bethesda system will be reporting either 4, 5 or 6. In this, 4 means it's a follicular neoplasm. This is very crucial to understand because the system is, whether the system is going to report it as a follicular neoplasm only, but not a follicular adenoma or a follicular carcinoma, because an FNA cannot differentiate between a follicular adenoma versus a carcinoma. You know this point very nicely because this is what is being asked since your second year exams, isn't it? FNAC cannot determine a follicular adenoma versus a follicular carcinoma because the definitive diagnosis of follicular adenoma versus carcinoma depends on whether you see this capsular invasion or vascular invasion or not. Clear? Very, very important point. So that's why you need a biopsy, and often we do a surgery. Previously, what it was thought is whenever you encounter follicular neoplasm, the surgeon will do a lobectomy and he will wait on table. We will send the lobectomy specimen to the pathologist where they will be taking the sample for frozen section, and once they do the frozen section analysis, it will come quickly within maybe 20-25 minutes. The pathologist will give the report as adenoma or carcinoma. Now, depending on the report, the surgeon will perform a total thyroidectomy. If the report comes as carcinoma, the surgeon will close off with the lobectomy and stop the surgery if the report comes as follicular adenoma. But right now, these things are all not done, to be honest. So 5 means it's a probable malignancy, and 6 means it's a definite malignancy. We know that. Clear? So what you're going to do in this condition? So obviously you're going to take for surgery. You're going to take for surgery. But wait on. Even before surgery, there is one thing that is missing here. So what is that thing? So I'll be doing a extensive and detailed neck ultrasound. I'll be sending the patient again for a detailed neck ultrasound. This is often sometimes very, very, very missed thing by many practitioners as well. You don't do that. Because yes, initially you did an ultrasound. Yes, all right. So we had some ultrasound criteria. You did an ultrasound. I'm not denying that fact. But this repeat extensive neck ultrasound and detailed neck ultrasound is very, very important because this time you are focused on finding out the lymph nodes. That's why you do this ultrasound. You are focused on finding out this lymph nodes in the first place. Remember, the reason why you want these lymph nodes is because it's going to completely alter the stage of the tumor. At the same time, it's also going to alter the treatment of the tumor. So that's why that's really important. If you have even a single lymph node that is positive in the neck grossly, that is visibly involved, definitely I would take for regional neck node dissection. So that's why this is really, really important. Do not forget that. So what surgery you will do? Either you can go for a total thyroidectomy, very commonly performed surgery, versus you can prefer a lobectomy or a hemithyroidectomy. There's no much difference between lobectomy and hemithyroidectomy, with the one difference whether you remove the isthmus or not. Lobectomy, only the involved lobe is involved, leaving the isthmus, and in hemithyroidectomy, you remove the isthmus as well as the involved lobe. So that's the only difference. But what you're going to do, so if you want to do conservative surgeries like this, there are some indications for doing this conservative surgeries. What are the indications? The tumor should be less than 1 centimeter, number one. Second, there should be no extrathyroidal extension, and this should be confirmed by the surgeon on table, which means there should be no microcalcification. There should be no involvement of the contralateral lobe, and there should be no involvement of contralateral lobe. Very commonly, PTC will have micronodularities in the contralateral lobe, and these kind of micronodularities should not be palpated on table. So very, very important. And next, if the patient doesn't have lymph node metastasis, again, that's why this extensive neck ultrasound and detailed neck ultrasound before surgery is really important. So you have to rule out lymph node metastasis absolutely. Then only you can do this surgery. Then there should be no family history of any thyroid cancer. At the same time, patient should not have any history of exposure to radiation to the head and neck area. If all these things are there, if every single thing is there, then you can go ahead with a conservative surgery like a lobectomy or a hemithyroidectomy. If there is even a single exception, any exceptions to what I have told, you do a total thyroidectomy. That's it, nothing else. Clear? Plus, you can do a lymph node dissection, but this is optional, depends on what is the type of involvement and what are the indications, whether it is there or not. So you're going to do a lymph node dissection. So there could be a central lymph node dissection, which is prophylactic. You can do a prophylactic central lymph node dissection, which means you will be excising the level 6 nodes, which are nothing but the pretracheal, paratracheal and the prelaryngeal nodes. Level 6 nodes, prophylactically you can excise. Or you can do a regional lymph node dissection, which means it's an extensive radical dissection. So what are the indications for doing a prophylactic central node dissection? So here you will be doing for all the PTCs that are more than 4 centimeter. So definitely you will be doing a prophylactic central lymph node dissection, and all medullary thyroid cancers irrespective of the size. In general, FTCs does not need prophylactic central node dissection because they don't have a lymph node metastasis. Regional lymph node dissection or radical neck dissection must be performed in case if even a single visibly involved node is there, either by ultrasound or either by your clinical examination of palpating the nodes. Even a single visible node is involved, visibly if it's involved, definitely yes, you have to take for regional neck node neck node dissection. That is also one reason this underscores the importance of doing an extensive detailed neck ultrasound before doing the surgery, because even a single node if it's present, you cannot do a conservative procedure. You have to go for a total thyroidectomy. At the same time, your procedure of lymph node dissection will be radical regional node dissection. You are not going to do a prophylactic central node dissection in this case. That's why that detailed neck ultrasound before doing a surgery becomes mandatory and very, very important. Often it is forgotten. Fine. So now you have did the surgery as well. So what are you going to do after the surgery? So now this step is over as well. So now what will be the next step for the patient? What next? So obviously there are two things that you have to do. One is you have to get the information from the pathologist, because the pathologist will be processing the histopathological examination and the specimens, and you have to collect the details from the pathologist. So as a physician and endocrinologist, and this becomes really important. So this will be managed by the endocrinologist only, and this is really important. And you have to contact the surgeon as well, and you have to collect the details from him, depending on how complete the surgery is and what is the whether there is any extrathyroidal extension or not. All these details has to be collected, because all this single detail is important for your post-operative management of the patient. So pathologically, what are things you're going to ask is the vascular invasion, is the type of the tumor, size of the tumor, type of the tumor, size of the tumor, exact size, vascular invasion, is there is any microscopic extrathyroidal extension, which means grossly the surgeon might be telling there is no extrathyroidal extension, but there could be any microscopic extrathyroidal extension. But if the surgeon has performed lymph node dissection, that will also be examined by the pathologist. So he or she has to comment on that also, how many pathological nodal involvement is there. So, there could be a lot of lymph nodes that will be excised and given to the pathologist, and they have to tell what is the size of these nodes, at the same time, how many pathological nodes are there, how many nodes that are really involved by the cancer. All these details are crucial for managing the patient in the next step. So these are some of the important details. And next thing, surgeon should be telling about the presence or absence of gross extrathyroidal extension. At the same time, he has to tell whether the surgery is complete or not, which means whether the lesion could be completely excised or not. Sometimes a lesion could be involving very vital structure very nearby, like a vital vessel like carotid artery, so they cannot excise completely. So you have to comment on the completeness of the surgery and the presence of visual and gross extrathyroidal extension. Clear? So all these things make a lot of sense in treating the patient. So whenever you are going to see the type, so this is what the examiners are fond of, because this is very trivial second year level question where the type will be either a PTC or an FTC or a MTC. Clear? So that's what you're going to see, or it could be anaplastic type. Anaplastic. So what will be typically seen in the PTC, papillary thyroid cancer in biopsy? I'll be showing the images, don't worry about that. But let us see the theoretical points now. So in PTC, you will be seeing papillary arrangement, but more than that, the nuclear features, that's what is very important. So the nuclear features are what is going to tell you it's a papillary thyroid cancer. The nuclear features, in the sense, there are two features. One is the clear nucleus that you see. This is often referred to as a orphan Annie eye type of nucleus. So orphan Annie's eye is without a pupil, it's clear. So that, like, if you see a nucleus like that, that's a suggestive of PTC like nuclear feature. And second thing, if you have a nuclear grooves, if the nucleus is grooved in between, sometimes this is also referred to as a coffee bean type nucleus. All right. So second, in a follicular thyroid cancer, you will be seeing a follicular arrangement. Follicular arrangement of the cells, and you will have nuclear atypia. But please note the fact that nuclear atypia cannot differentiate between a follicular adenoma versus a follicular carcinoma. It can be seen in both follicular adenoma versus follicular carcinoma. Plus, at the same time, there will be no nuclear features of PTC. Typically, there will be no nuclear features of papillary thyroid cancer. And at the same time, these patients with follicular thyroid cancer will be having either a vascular invasion or a capsular invasion. And this is what is going to tell it's a definitive follicular thyroid cancer. If this is not there, you will be diagnosing as a follicular adenoma only. Fine. Then MTC, we know that. So they're going to have a spindle cells that are arranged in nest-like pattern, and they will be having a characteristic amyloid stroma. And you know like what they're going to have. They'll be thyroglobulin negative. Remember, on staining, definitely this PTC and FTC will be thyroglobulin positive, whereas this MTC and anaplastic tumors will be thyroglobulin negative. And in anaplastic cells, anaplastic carcinoma, you will be encountering a different histopathological picture. Like again, you'll be seeing these giant cells which look like osteoclasts, and you will be seeing this spindle-like cells and completely de-differentiated, and they'll also be thyroglobulin negative, and they won't have calcitonin as well. So they won't have this amyloid stroma that is made of calcitonin. They don't have this calcitonin positivity. So this you will diagnose as a anaplastic cancer. These points in HP are really important as far as exams are concerned. At the same time, you might be asking me, what will be the diagnostic findings of a FNAC? So FNAB has, even though they give by Bethesda system, but FNAB has some characteristic features that are suggestive of a PTC, FTC, MTC, and a anaplastic thyroid cancer. Even in FNAC itself, you can make a wild guess. But even though they will be giving us Bethesda system only, but still, they can give a wild guess. So PTC, once again, like you might see papillary arrangement here in PTC, but not exactly, but at the same time, there will be some nuclear features that are visible. The nuclear features of PTC that is seen in FNAB often are thought to be like intranuclear inclusion bodies. These are mostly eosinophilic. You can see these intranuclear inclusions, or these are also referred to as intranuclear bubbles. So this is what is characteristic of a PTC. Then, what about FTC? FTC, mostly you will be seeing follicles where there will be 6 to 12 cells or 6 to 12 nuclei arranged in a follicular pattern. Plus, similar to what we saw in the frank histopathology, there will be no nuclear features as well. Remember, if you do an FNA washout, we know how to do a washout. I have described this in MTC itself. If you do an FNA washout, there will be thyroglobulin positive. Very important point. So, in an MTC, you're going to see this spindle and pleomorphic cells. But more importantly, they won't be having any follicular arrangement, nor they'll be having any nuclear feature suggestive of PTC. But very importantly, this FNA washout will be calcitonin positive rather than thyroglobulin positive. They'll be thyroglobulin negative, but calcitonin will be positive here in FNA washout. And if you put markers, again, they'll be thyroglobulin negative, they'll be calcitonin positive, and a lot of other markers I told you, synaptophysin positive, chromogranin positive, that will tell you it's likely to be an MTC. Then anaplastic tumor, you'll be seeing the same giant cells, which might look like osteoclasts, or you might see some spindle cells. But very, very importantly, there will be severe nuclear ATP and mitotic figures, because it's a very, like undifferentiated tumor. It's very high grade, undifferentiated. So the nuclear mitosis will be in a great extent. At the same time, FNA washout will not yield anything. And you know the history. History-wise also, you can tell most of these patients will come with obstructive features. So you know the history, clinical findings, age of the patient, elderly patient, more goes towards anaplastic thyroid cancer. FNA washout will neither be positive for thyroglobulin, nor it will be positive for calcitonin. At the same time, typically if you do a TTF1 stain, it will be negative, it will be PAC site negative, it will be thyroglobulin negative, it will be calcitonin negative also, but it will be positive for P53, right? When you do a histopathological staining, it will be positive for P53. So these are the features that will tell you to an extent, not completely, that it is a possible malignancy, type of malignancy. But still, the most important thing is they will be giving the reports in form of a Bethesda system only. Now let us see how you are going to use all this data for assessing the post-operative risk status and further treatment of the patient. So I'll be using all this data, as I told you, to initially risk stratify the patient. So I'll be first doing initial risk stratification. So once I have done the initial risk stratification, I know the risk. Now I'll be pushing on to the initial management after the surgery. So after the initial management, I'll be further moving to long-term follow-up. So what I'll be doing in the long-term follow-up? What is the TSH suppression? How much TSH I have to suppress? All these things. Fine. So initial risk stratification, in the sense, there are two things that you have to do. So first you have to tell the patient, and you have to know yourself what is the mortality risk of the patient. So for telling the mortality risk to the patient, and for yourself to know what is the mortality risk of the patient, we have various scores like MASIS score, or we can have this AJCC-TNM classification also. Currently we are using the 8th edition, right? From 2016 we have been using the 8th edition. This MASIS score is outdated, to be honest. That can tell the 20-year survival. So let me first finish off the MASIS score, which is traditional. First one stands for the distant metastasis. We're talking about distant metastasis, not the lymph node metastasis. Distant metastasis, if it is there, the score is +3. You can add to it. And if you have, you can see based on the age, that is what the second thing. So MA, isn't it? So you have the age. It's an acronym. So you have age for A. And if the patient is age less than 40, that is 39 years and less, you can put a score of 3.1. Plus, if the patient is age 40 and above, you have to give an additional correction by multiplying 0.08 into age. In the sense, this is done if the patient is having age 40 or above. So this additional correction should be given. Apart from this 3.1, you have to add this additional correction part. The patient's age is 40 and above. Then C stands for completeness of the surgery. If it is incomplete, you will be adding +1. If it's incomplete surgery, or if there is any extrathyroidal extension. I stands for invasion given by the pathologist report. If it's invasion, you will have +1 if it's invasive. Then finally, you're going to tell about the size of the tumor. The size is, the score is given as 0.3 multiplied by size of the tumor in centimeters, the resected specimen. So, but very importantly, you have to understand the MASIS score is applicable only for papillary thyroid cancer. It's not applicable for other types of thyroid malignancies. You have to be very clear about that. So this is the acronym. So metastasis, age, completeness of surgery, invasion, and size of the tumor. This is the MASIS score. So based on the score, you can assess the 20-year survival. That's the idea. So you're going to tell the mortality risk. The 20-year survival as per the MASIS score any score 7 and above is going to have a poor prognosis and high mortality. Let us see how. So score of 6 to 6, less than 6 first, is going to have a 99% 20-year survival, excellent prognosis. Score of 6 to 6.99, 89% survival, and 7 to 7.99, 56% survival. You can see the fact that the score drops to, the survival drops dramatically from almost 90 to almost 50%. The score reaches 7 and above. The score is 8 to 8.99 or anything more than 8, you have only 24% of 20 years survival. So this is a very important score, and only for exams, but in reality we follow currently the AJCC TNM classification. And the other scores similar to MASIS have come, that's called the AGE score, and we have AM score, and these are currently not preferred that much compared to that of the AJCC 8th edition classification. So what are the significant changes that have been done in the AJCC 8th edition? I'll tell you before itself. One is the age limit, age bar. Previously it was, there was a classification for younger age and older age, which was 45 years. Right now, there is a drastic change, it was 55 years. So the definition for a younger age and older age is 55 years, not 45 years. Second, lymph node involvement is no longer stage 3, it is in stage 2 only. Previously it was stage 3. And the third one is the extrathyroidal extension. If you have only minor extrathyroidal extension, it is not 3 nowadays, it's only stage 2. Only major extrathyroidal extension will go to the stage 3. So these are the 3 major changes that have been brought in the 2016 8th edition AJCC TNM grading. So let us see what is the AJCC TNM staging tell. So I'm going to show a table for you. So this table will help you understand a lot of stuff. And you can see the first change is the age, less than 55 or 55 and above. So this is what is the definition of young according to the new AJCC TNM, and this is the definition of old age according to new AJCC TNM. And you can see only one thing that makes a difference in younger patients, that is whether or not the presence of distant metastasis. So remaining all these things don't make any difference at all. So less than 55 years, you have only 2 stages, either stage 1 or stage 2. In fact, they have a good prognosis and a good survival. So in fact, stage 1 patients have almost 98.9% 10-year disease specific survival rates. It's very good. So again, younger patients by default have a better prognosis, even in the presence of a distant metastasis. And that's the only thing that matters in the younger patients. But older patients, more than 55 years of age, all these things now come into play. The extrathyroidal extension, tumor size, lymph node status, then distant metastasis, everything is important in these patients. And one important notable point is the fact that nodal involvement will be still under stage 2 only. So once the patient becomes stage 3, the nodal involvement doesn't make any significance or doesn't make any sense at all. And again, the tumor size is important only up to stage 2. After stage 2, the tumor size is again not important. It's only the gross extrathyroidal extension that makes sense, which pushes the patient towards stage 3 and 4 ahead. So that's why this is the most important as far as old patients are considered. How I told you, in younger patients, the distant mets are the most important. Like that, in older patients, the extrathyroidal extension is the most important. That's going to make the prognosis worst. And you can see only minor extrathyroidal extension, which means involving only the strap muscles, will be under stage 2 only. Previously, it was stage 3. That's a notable difference in the new classification. And major extrathyroidal extension is the one that's going to push the patient towards a lot of stages forward, like stage 3, stage 4A, and stage 4B. What is the T staging of thyroid cancer? You have T1, T2, T3, and T4, right? So T1 means you have T1A and T1B. T1 and T2 is totally based on the size of the tumor. T1A is less than 1 centimeter tumor, and T1B is 1 to 2 centimeter, which means overall T1 means it should be less than 2 centimeter size. T2 means the tumor is 2 to 4 centimeter size, and definitely in T3, the patients will be more than 4 centimeter, and again you can divide into A and B. So A means more than or equal to 4 centimeter, and T3B means they are involving extrathyroidal extension, and this extrathyroidal extension will be only minor in T3B, involving only the strap muscles, right? And T4 indicates, like again you have A and T4B. T4A indicates, T4 means itself is a major extrathyroidal extension. In the sense, T4A means you're going to involve the locoregional structures like your trachea, esophagus, probably your other areas nearby, and larynx. And T4B means you're going to encase major vessels like the carotid sheath, or you're involving the prevertebral fascia. So this is T4B, right? So this is the T staging, and very important in exam, what you're going to confuse is the fact that you're going to confuse with this T staging with the actual staging, right? Remember the fact that T staging may not correlate with the actual staging. So please be very careful during the exams. So this staging is the one that's going to tell you the mortality. This final staging is going to tell you the mortality risk of the patient, because there is one thing that you have to know is the mortality risk, because the patients are going to ask you, what is my mortality risk? Whether I'm going to die or what is my probability of survival. So if you don't know this, you can't answer that question. So this is a very important classification system. So fine. So now you have finished the AJCC TNM. So this is what you're going to use it, obviously. So next thing, you have to know the ATA risk, this American Thyroid Association risk. So why I have to know the ATA risk? Because only if you know this, you can proceed ahead with the next step, that is initial treatment. In the initial treatment, I'm going to use two things. One is radioactive iodine ablation, that's post-op RAA. Second thing is your TSH suppression by giving levothyroxine. So how much TSH to be suppressed, and whether you will give a radioactive iodine ablation or not, how will you answer? Only by knowing the ATA risk. That's why this knowing the American Thyroid Association risk is really important. So based on ATA risk, I can put them under a low risk, or put them under intermediate risk, or put them under high risk. Low risk is very simple for a PTC. As far as PTC is concerned, if it's a classic PTC, carries a low risk only, or if there is no invasion by a PTC, papillary thyroid cancer, comes under low risk only. And if you have no vascular invasion, there are some PTCs which can go for vascular invasion. So if there is no vascular invasion, I'll be putting it under low risk PTC only. And if the surgeon tells there is absolutely no extrathyroidal extension, in the sense he has completely resected the tumor, and even the pathologist has agreed to the surgeon, there is not even a microscopic extrathyroidal extension. So this, I feel, is the most important thing that comes under the low risk. Clear? No extrathyroidal extension, either microscopically or macroscopically, it's a complete resection. Obviously, if the surgeon has done a lymph node dissection, he will also give multiple nodes, like 15, 20 nodes he will be giving to the pathologist, and the pathologist has to examine each and every node individually, and he or she has to give the pathological nodal involvement. How many nodes are pathologically involved by the tumor and their size? All these things have to be commented. If it is less than 5 and all the pathologically involved nodes are less than 2 millimeter, that is 0.2 centimeter. So this again puts the patient under low risk if it's a PTC. Then what about the FTC? So if it's an FTC, you have to tell if it is less than 4 foci of vascular invasion. So don't tell that if there is vascular invasion, FTC means high risk. No, not at all. FTC can be diagnosed only if there is a vascular invasion, isn't it? So definitely they are going to have vascular invasion, but if there is less than 4 areas in the slide where they're going to have vascular invasion, I can put it under low risk. If it's more than 4, it's a high risk. That's why. And a variant called EFV PTC, isn't it? The intrathyroidal EFV. If it's intrathyroidal, as long as it's intrathyroidal, there is no extrathyroidal extension, this will again come as a low risk only. So this is for FTC and its variants. Clear? Fine. So these are the ATA low risk category. And ATA also has some intermediate risk categories. What are the like points that will come under ATA intermediate risk? Number one, I mean, this is usually for PTC only. We don't consider FTC. Remember, MTC as a completely different thing. So we don't worry about MTC. And anaplastic, again, we're not going to be worrying about that as well. So that's completely a conservative and a palliative management. So we are talking about PTC and FTC in detail here, which I told multiple times before starting this topic. So intermediate risk, number one, if you have a microscopic extrathyroidal extension, which means grossly the surgeon disagrees that there is some extrathyroidal extension, but pathologist tells there is some microscopic extrathyroidal extension is there. And if you have aggressive histological types of PTC, like your tall cell variant or columnar variant or hobnail variant, Hurthel cell variant, like aggressive histological types of PTC. Now you have a PTC with vascular invasion. I told you here PTC, usually if there's no vascular invasion, that puts them under low risk. If it's with vascular invasion, that puts them under intermediate risk. Then pathological nodal involvement, more than 5, but all less than 3 centimeter. Less than 3 centimeter will come under intermediate risk. Then if you have a central nodal involvement, that puts them under intermediate risk. Number 4, number 5, number 6, finally, if you have a multifocal papillary thyroid cancer, it's a papillary microcarcinoma. It means small bits of multifocality is there, and if they are BRAF mutated, multifocal papillary microcarcinoma plus BRAF mutated variant. So these are the 6 things, but as far as you know, in exams, this becomes the most important, and probably this becomes the most important as far as I know for the exam. So these 3 things put under intermediate risk. And what are things that will come under high risk? High risk is very simple. If the patient has a gross extrathyroidal extension, which means surgically incomplete, it's an incomplete resection. Surgeon couldn't do the resection completely, possible, because it could be encasing the major vessels. You can't do the resection completely in that case. Incomplete resection, or if the presence of distant metastasis, right? Distant metastasis. Then if the patient has pathological nodal involvement or any node more than 3 centimeter. You have an involved node in pathologically. You can see the tumor cell rests in the node, and the node is very bulky, more than 3 centimeter, bulky nodes, high risk. Then if you have follicular thyroid cancer with more than 4 foci of vascular invasion. We studied this already, isn't it? If it's less than 4 foci of vascular invasion, that is low risk. If you have more than 4 foci of vascular invasion, that is definitely high risk. So this is how you're going to classify based on the ATA risk, whether it's low risk, intermediate risk, or high risk. So where they will concentrate in the exams. Remember, first is the extrathyroidal extension. First point, this is the most important. So no ET whatsoever, microscopic or macroscopic, low risk. Then second, microscopic ET puts under intermediate risk. Macroscopic, gross extrathyroidal extension, incomplete resections put them under high risk. And distant metastasis put them under high risk. Follicular thyroid cancer, if it's less than 4 foci of vascular invasion, put them under low risk. If it's more than 4 foci of vascular invasion, put them under high risk. Aggressive PTC variants, put them under intermediate risk. That's it. Clear? So these are the exam points. That's all. I don't think other things they might be asking. So, and this is the one that's going to tell you whether to do a radioactive ablation or not, or whether to do a TSH suppression or not, and how much TSH to suppress. That's what this ATA risk is going to tell you, because this is crucial to understand. That's why. So radioactive iodine ablation, whether you'll give or not, yes. What are the indications? Usually we prefer giving this in a patient who's having a high risk and a patient who's having intermediate risk. Usually all patients of high risk and most patients of intermediate risk. Again, there are some selectivity criteria there, but I don't want you to confuse more and more. You can remember as intermediate risk and high risk according to ATA, which I have described you sometime, will tell you that these patients are candidates for radioactive iodine ablation post-op. Clear? And the low risk patients typically need not be taken for radioactive iodine ablation, and it all depends on your individual preference, but generally not needed. Fine. So then, what is the type? How will you do this procedure, radioactive iodine ablation post-op? So you have to give radioactive iodine ablation by I-131, and the dose is 100 millicurie. That's what we give. But how will you prepare the patient? So that's really, really important for exams again. So remember, the TSH is really important for taking up the iodine. So these cancer cells grab up on the iodine, and for them grabbing on the iodine, your TSH is really important. So you need to have a substantial amount of TSH that would stimulate these cancer cells to take up the radioactive iodine. So you need to have some amount of TSH, at least a little decent amount of TSH in the blood. So the usual target TSH is typically more than 30, and some guidelines tell 20 to 30, doesn't matter. ASE guidelines and ATA classification clearly tells it's more than 30. This is what the target TSH you have to maintain. And this target TSH can be achieved by two principles. One, by thyroid hormone withdrawal, which means patient would have gone for a total thyroidectomy. If you don't give any thyroid hormone itself, automatically by feedback, because there is no thyroxine in the body, the TSH will start rising. Or you can use thyrogen. Thyrogen is nothing but a recombinant TSH. I mean, this is a slow way. It takes 4 to 6 weeks approximately, but this is very fast. You can achieve the target TSH within a couple of days, within 24 to 48 hours. At the same time, second thing, the patient should have low iodine diet for 2 weeks at least. Low iodine diet for 2 weeks. You have some supplements regarding what are the foods that contain high iodine, and the patient should avoid all those foods that have high iodine. And subsequently, they can either follow a thyroid hormone withdrawal, or at the end of low iodine diet, they can go for a recombinant TSH or a thyrogen. So once you have achieved the target TSH with low iodine diet for a couple of weeks, then you can go for radioactive iodine ablation with I-131. We know why we use I-131, because of the higher half-life. And once you have used this I-131, and what is the dose of the I-131 you give? It is approximately 100 millicurie. This is the dose we prefer. And traditionally, we used to follow the doses up to 600 to 800 millicurie, but that is associated with high risk of side effects like second malignancies and infertility and all. But right now, we don't give such high doses. We prefer only giving a 100 millicurie. You might need a couple of sessions extra, but most of them will respond to a single session usually. And after this post-operative radioactive iodine ablation, what next? So, but before that, what are the side effects of this radioactive iodine, I-131? You can get a nausea, dry eyes, and altered taste, parotitis, dry mouth, altered taste, and probably a risk of second malignancy. And this is very rare with the current dosing. At the same time, they might have effect on fertility. Again, these two are very, very rare side effects with the current dosing. We don't get these side effects. So you can tell the patient very clearly. And as far as your radioactive iodine ablation is concerned, once you have finished the procedure, you have to take the patient for post-treatment whole body scanning with radioactive iodine ablation again. With radioactive iodine again. We use again for this purpose, we use 131. We don't use 123 for this purpose. We use 131, and you can identify the residual disease. And again, based on this itself, again, you can risk stratify according to American Thyroid Association classification, if the post-treatment whole body scanning shows uptake only in the thyroid bed, that's normal. Only in the thyroid bed, that puts them under low risk. Anything beyond the thyroid bed, in the neck or any distant metastasis after giving radioactive iodine ablation, put them under high risk. Clear? So if you see uptake negative anywhere in the body, or uptake positive but only in the thyroid bed, area, that puts them under low risk, ATA low risk, fine. If elsewhere, probably in the neck, outside the thyroid bed, or if you have a distant metastasis somewhere, this puts them under ATA high risk. This point I didn't tell purposefully, because otherwise it will be confusing there. So you know the risks after radioactive iodine ablation also. So this is how you do a radioactive iodine ablation. And second thing which we have not discussed is the TSH suppression. Remember, if you are planning for radioactive iodine ablation, don't give TSH suppression immediately and do the TSH suppression after the radioactive iodine ablation. So how much suppression? That's the question. How much TSH suppression? The normal TSH we saw already, it's in the range of 0.5 to 4.12, but what is the range of TSH suppression? It depends on whether it's a low risk or whether it's a intermediate risk or whether it's a high risk according to your ATA risk, which we have stratified some time back. If it's a low risk, you can maintain the patient in the euthyroid range, which means in the 0.5 to 2 range. If it's intermediate risk, I'll be maintaining at 0.1 to 0.5 range. If it's high risk, I'll be maintaining at less than 0.1 range, which means there should be literally no TSH in the blood. Because high risk means there is a lot of risk of reactivation of these cancer cells, and if TSH is there, these are follicular tumors and TSH might stimulate the tumor growth. It's a trophic hormone, you know that. So you have to maintain it less than 0.1. So that is the reason I told you to know what should be your initial treatment after the surgery. You have to know the ATA risk. Without that, you can't tell all these things at all. Fine. So now you have done all these things. What about the long-term follow-up? The idea of this is to understand how long you are going to give TSH suppression and what is the further plan. That's what the idea is. So long-term follow-up is based on two things. One is the thyroglobulin levels, because we are dealing with FTC and PTC here, which are follicular-derived neoplasms. And based on whether the patient is having a recurrence or a persisting disease anatomically. So this is what we are going to assess. So this is first is the biochemical assessment, second is the structural assessment. So biochemically, I want to know what is the thyroglobulin targets. So thyroglobulin should be less than 0.2 if it is unstimulated. And some people do stimulate thyroglobulin, with TSH and find out the thyroglobulin levels, which should be less than 2 if it's a stimulated thyroglobulin. But overall cutoff, you can keep it as 0.5 for unstimulated, but generally more rigorous measurements like less than 0.2 is important to understand that the disease is completely suppressed. And this is the target if you have done a total thyroidectomy. But if you have done a lobectomy or if you have done a hemithyroidectomy in selected candidates, we have discussed already. So here the thyroglobulin target will be less than 30. This is a vague number, not having good evidence for this, but still this gives a excellent prognosis in the future. So less than 30 is a good number for these patients. But for total thyroidectomy patients, less than 0.2 or less than 2 if it is stimulated. So based on this, how I'm going to tell, I'm going to divide where the patient is having a excellent response. Excellent response is defined as where the patient is not having any thyroglobulin positivity, which means thyroglobulin is below the cutoff. I call it as thyroglobulin negative. At the same time, patient will have no evidence of locoregional disease or distant metastasis. No evidence of locoregional or distant metastasis. Fine. Second, I can call it as a biochemically incomplete response. What do you mean by a biochemically incomplete response? The patient will not have any evidence of locoregional disease or distant metastasis, but patient will have abnormal thyroglobulin values. This is what we refer to as a biochemically incomplete response. Then third one, structurally incomplete response. So what do you mean by a structurally incomplete response? If the patient is having evidence of, whatever maybe a thyroglobulin doesn't matter, if the patient has evidence of locoregional disease or distant metastasis, definitely it's a structurally incomplete response. So this locoregional disease or distant metastasis might be either persisting, which means they didn't respond to your treatment at all, or it could be new, which means we call it as a recurrence. It could be a new thing. Once it's responded initially, but it came out as a new entity in the time being, when you are evaluating and following up the patient. Apart from this, you have a fourth entity called indeterminate response also, where the things are confusing. Thyroglobulin may be 0.4, 0.6, is not very high also. And at the same time, your lesions are there somewhere in the neck or somewhere else in the body, but you're not able to tell for sure it's a recurrence or it could be something else. So we don't know. So these are something we refer to as an indeterminate response. We have to observe and follow up. So what will be the TSH goal? That's the idea. TSH goal in each of these responses. TSH goal in patients who are having structurally incomplete response, definitely it should be very rigorous, and you have to suppress the TSH completely to less than 0.1 by giving high dose thyroid hormones, levothyroxine. Because it's structurally incomplete, you have clear evidence of a persisting or a new recurrence, and this disease will accelerate if there is sufficient TSH, because they respond to this TSH and their TSH is a trophic hormone. So you have to maintain it less than 0.1. Absolutely no doubt about that. And if it's a biochemically incomplete response, you can maintain long term. We are talking about the long term TSH suppression. Here we're not talking about the early TSH suppression, which is done previously. We are talking about long term TSH suppression. We will be biochemically incomplete, maintain at 0.1 to 0.5, and indeterminate response again maintain at 0.1 to 0.5, most of the cases. And in case if the patient is having an excellent response, if it's a low risk patient, you can maintain at a more liberal level at 0.5 to 2. And if it's a high risk patient according to ATA, as per the previous information which I have given, it should be in the 0.1 to 0.5 range if it's an excellent response. Again, the long-term follow-up and TSH suppression depends on the ATA risk. That's why I told you ATA risk is really, really important. And this is not a very stringent target, because since it's a long-term TSH suppression, this is a long-term treatment, and your TSH goal has to be balanced with a lot of things like menopausal status, bone health, osteoporosis, because very high T4 can result in high dose of thyroxine hormones. If you're giving exogenously, that might result in osteoporosis. A patient who's fractured and debilitated for life, not a good thing. And you have to balance the risk against cardiovascular status. You have to balance the risk against presence or absence of atrial fibrillation. A lot of things are there. The patient is already having cardiovascular risk, and patient has known case of MI. Giving such a high thyroid hormone may result in tachycardia, precipitate a new MI, patient might die, which is not warranted. Whether the tumor kills or not, the high thyroxine hormones might kill the patient. So you have to balance against these also. If some of these or all of these are there, you might try to an extent to relax the TSH cutoff by giving a little lesser dose of thyroid hormones. But again, depends on the response. The response is the most important for the TSH goal. Clear? So I think theoretically we have completed the discussion of the thyroid cancer, but let us see some of the images, what I promised to show you. These are the FNA images which I want to show. So this is an FNA image of a papillary thyroid cancer. You can see in low power, you can see they are arranged in some papillary configuration. So this is a low power image. And in high power, you can see the characteristic nuclear features of PTC. You can see this is the nucleus. In the nucleus, you can see some inclusions. Your intranuclear eosinophilic inclusions, or you might get this intranuclear bubbles. So all these things go towards papillary thyroid cancer. Right. So these are the histological pictures of FTC and PTC, classic biopsy findings, HP images of PTC and FTC. So first one is the PTC and second one is the FTC. All right. So in PTC, what you are supposed to see is this papillary configuration. You can see this nice papillary configuration. Here, you can see this nice papillary kind of configuration with a fibrovascular core. So this is the classic description. You're going to have a fibrovascular core, characteristic description. And if you go to the nucleus, and if I zoom in the nucleus and see, and I can see some Samama bodies also, even though it's not specific. This is an example of a Samama body, non-specific. It can be seen in many other conditions. And if you see nucleus, can I see this clear nucleus? Yes, a lot of nucleus are very clear. I can see the nucleus is very clear. And this kind of clear nucleus, you can see there's a nucleus very clear. And this kind of clear nucleus, I can call as Orphan Annie eye appearance. Just Google it, Orphan Annie's eye. It doesn't have a pupil, very clear eyes. So the nucleus looking like that, that's called a clear nucleus, Orphan Annie eye nucleus. And you can see some Samama bodies, I think. I think this is also an example of a Samama body. Here, if you want, I can show it here. This is the example of a Samama body. And this is a Sama body in close-up, and this is how it looks like, a squamous wall, and some calcifications will be there. This is Samama body, and this can characteristic 3 tumors that shows Samama bodies: serous cysternoma of ovary, papillary thyroid cancer, and meningioma. So this is what you have to know for the exams. There are a lot of other cancers as well, but these 3 are very important: papillary thyroid cancer, serous cysternoma of ovary, and meningioma. And this is a typical histopathological image of a follicular thyroid cancer, where you have a larger nucleus, isn't it? This is not a smaller one. This is definitely a large nucleus. If you go back to our physiology of the thyroid gland, where I have discussed a cut section of the thyroid gland, how it appears normally. So the nucleus must be smaller. So you have a large nucleus here. At the same time, this is what we call as nuclear atypia, and they are arranged in nice follicles. So they are still arranged in nice follicles only. And this alone will not tell you. And you don't have any nuclear features. You can see the nucleus doesn't have any clarity here. So nucleus is well stained, and there is no nuclear features that are suggestive of PTC. Very important point again. No nuclear features suggestive of papillary thyroid cancer. And all these things alone will not tell you it's a follicular carcinoma. You have to prove the presence of vascular invasion. So this will tell you whether the patient is having a follicular thyroid cancer or just a follicular adenoma. Let us move on and discuss the atypical cases like your anaplastic and the medullary thyroid cancer. These images show you the features of anaplastic cancer. This is a HP image of anaplastic thyroid cancer, where you're going to see this kind of giant cells. So these are giant cells, osteoclast-like giant cells. You can see this irregular shape, and these are the spindle-shaped cells. Fine. And once again, this is another image, histopathology image of anaplastic cancer. You can see this multinucleated osteoclast-like giant cells, and you can see a lot of spindle-shaped cells also. And this is a histopathological image of medullary thyroid cancer. And this is actually a cytology image rather than a histopathological image. This is an FNA image of medullary thyroid cancer, where you don't see much findings, very non-specific findings like this salt and pepper nucleus. So this is salt and pepper nucleus here. So you can see, like there is some salt and pepper configuration here. So this is not specific again. So don't think this is a specific sign. And this inner picture shows that these patients are calcitonin positive. They stain positive for calcitonin. That's really important. And you can prove in histopathology. So this is a HPE section where you can see that this patient is having tumor cells that are loculated here, this area, and you have a lot of amyloid stroma. This pinkish color, C-like appearance you see is like amyloid stroma. So you can shade it if you want. So all these are amyloid stroma here. So this is due to calcitonin deposition. Classic. And I'll finish off this image. This image is very classic again, and you can see this characteristic nest-like cellular configuration. So this nest-like cellular configuration, very characteristic. Again, in low power you see, this is suggestive of an MTC if you take from the thyroid. This can be seen in many other tumors like other neuroendocrine neoplasms, pheochromocytoma, many things can show this nest-like configuration. So this is not specific. In thyroid, it becomes relatively specific for a medullary thyroid cancer. And once again, this is a nesting configuration where you can see a lot of nest-like appearance of cells along with amyloid stroma in between. These are the pinkish amyloid that you are seeing in between. So these are the amyloid stroma, and this is again suggestive of a medullary thyroid cancer. Clear? So with this, we have completed in entirety about the thyroid cancer in complete detail and great depth. I think we can close the session off, and in the next section, we'll be discussing on the functional thyroid disorders, that is on hypo and hyperthyroidism.